I was sort of thinking, Martine gave me a list of things to cover, and I think quite a lot of you this time are probably new to the meeting. So I'll talk a little bit about what I understand by PSC, a little bit about some of the symptoms, about what we look for as clinicians when we're assessing patients with PSC, and then a little bit at the end about what I understand as how this disease develops and maybe where there are some areas that we can try and treat it more efficiently in the future. And as I was thinking about this, it actually dawned on me that it's 30 years almost since I came to work at the Queen Elizabeth Hospital and I first met patients with PSC. And things were very different in those days. Liver transplantation was just starting. So the unit here at the QE had done about 10 transplants. We've now done, what is it now, guys? About 4,000. And we had, one of the early patients had been transplanted for PSC, but unfortunately hadn't made it. And I remember we were referred patients from all over the country, and they would come to us deeply jaundiced with their muscles wasted away, with tummies full of fluid, and really too sick for us to be able to effectively transplant them. And that was really for the first time when we began to think about PSC in a different light, because with transplantation we had a chance to cure patients. So we spent a lot of time talking to our physicians around the country to actually persuade them to send patients to us earlier so that we could assess patients properly and put them forward for transplantation. And of course that revolutionized the treatment of PSC. And one of the things that came out of that was the idea of actually developing specialist clinics for PSC. So one of the first ones was set up by Roger Chapman in Oxford, and I set up the clinic here about 15 years ago. And I think that's really important because PSC is a rare disease, and one of the problems is if patients are being seen scattered throughout clinics all over the place and the doctors looking after you only ever see a handful of patients, they never really get to understand the disease. And it was bringing patients together in specialist clinics that really began to transform our understanding of the disease, the clinical aspects and the treatment responses, when to refer patients for transplantation. And I've reached a stage in my career now, I'm the Dean of Medicine here and a Pro Vice Chancellor at the university where I have to give things up. And with some reluctance, but actually it's in incredibly safe hands. I've been able to give up the PSC clinic to James first, who worked with me, and then Gideon, and now Gideon and James run that clinic. And it's been enormously successful, and it will continue and go from strength to strength. So that's a little bit about history. What is primary sclerosing cholangitis? So it is actually what it says it is. So it's primary, and the primary means that there isn't an obvious cause that causes the disease. So we know in other situations you can have secondary sclerosing cholangitis. So if you have surgery which goes wrong and your bile ducts become damaged, or if you have very aggressive gallstone disease and you get stones in the bile duct and that damages the bile ducts, or in patients who get infections in the Far East, a parasitic infection called Clonorchis, which is a worm, can stimulate damage to the bile ducts. And all of these diseases can cause a disease that looks very like PSC, but that's secondary sclerosing cholangitis because it's occurring secondary to something else. Primary sclerosing cholangitis occurs without any obvious precipitating cause. The sclerosing bit means narrowing, so you've probably all heard of atherosclerosis. That's narrowing of the arteries that supply the heart. So that means narrowing of the ducts, the bile ducts in the liver. And when you get a narrowed duct, which is supposed to drain something, that causes fluid to flow slowly, to build up, and then there's a risk of infection, and that's how we can get cholangitis. And then the cholangitis bit, the cholangio bit means the bile ducts, and the itis means inflammation. So actually, if you put it all together, it describes what PSC is very well. And what is really going on in PSC is that the bile ducts, which drain the bile out of your liver into the gut, are being damaged and destroyed. And we now know pretty conclusively that this is what's called an autoimmune disease. So the reason that bile ducts get attacked and damaged is that your immune system, which is there to fight off viruses and bacteria and to protect you against abnormal cells that might develop into cancer, for some reason sort of sees your biliary system as one big infection that it's got to attack. And the problem is that attack perpetuates. It doesn't stop. It keeps attacking. And one of the consequences of that attack is that you have inflammation, which is the cholangitis, and then that inflammation turns to scar tissue, and that's fibrosis. And that's when the ducts get narrowed and deformed because scar tissue forms, and that prevents the ducts draining properly. And if that really becomes severe, in some patients, not all patients, but in some patients, that can then develop to cirrhosis. And cirrhosis is just a particular pattern of scar formation throughout the liver. And some of you who may have had cirrhosis and the complications of cirrhosis will know that scarring of the liver means that the blood doesn't flow through it properly, so you can then get consequences like the dilated veins in esophageal varices because the blood has to flow around the liver and back into the circulation, or you can get back pressure and the formation of ascites. So that's really what PSC is all about. But of course to you people, it's a pretty horrible, devastating disease. To us, it's an absolutely fascinating disease. I'm sorry about that, but it is. As I say, I've been looking after patients with PSC for nigh on 30 years, which makes me feel really old. But my lab has been working on really trying to understand PSC from the late 90s. And there are several things about PSC which are unusual and intriguing. And of course, the most dominant one of those is as Martine mentioned earlier, the link with inflammatory bowel disease. So most people with PSC will have inflammatory bowel disease. Even if that inflammatory bowel disease doesn't have marked symptoms, if we actually look at your bowel under the microscope, we often find what's called microscopic inflammation in the bowel. So there's something about inflammation in the bowel and inflammation in the liver. And over the years, we've worked hard in the lab here in Birmingham to try and understand what that link might be, and we think we're getting closer to understand that. But there's really other autoimmune diseases cluster together, but there's really no other combination like this link with inflammation of the bowel and PSC. So that's a really fascinating aspect of the disease. So I'll come back to that at the end. But Martine also asked me to talk a little bit about some of the symptoms that you get and how we assess you and what we actually look at when you come to the clinic to decide how your disease is progressing and what we're going to do next. And one of the things that's again interesting but slightly frustrating about PSC is it's very difficult to predict how it's going to behave. So there are other liver diseases, and the one that often gets put together with PSC is PBC, primary biliary cirrhosis. And that's, again, an autoimmune disease that attacks the bile ducts, but it attacks just very, very small bile ducts in the liver. It doesn't attack the bigger ducts that drain out of the liver. And in PBC, and Gideon is also a world authority in PBC, but that disease is actually much easier to look after because we don't have the inflammatory bowel disease and because we can predict fairly well actually what's going to happen to patients. We can predict when they need to be transplanted. But of course, one of the problems that many of you will know in PSC is the disease comes and goes. So you can be almost at death's door and then respond and improve, and a year or so later your liver tests are pretty much back to normal and you're doing well. So one of the problems we had early on when we first started being referred patients to think about transplantation was actually trying to decide when is the stage, when have we got to the stage where the disease is just going to progress relentlessly? And that can be really difficult to do. So what do we look at and how do we assess you when you come to clinic? Well, one of the most important things is actually, and this is why it's important that we have specialist clinics, is actually knowing your history, what's happened to you before and how your disease has behaved in the past. Because if you are one of the patients whose disease comes in these waves and goes up and down, then if you're in a bad trough, we can look at the past records and say, well, actually, we did this, and things improved and settled down. Other patients who may have been stable for a long time and suddenly deteriorate, then that may make us worry more that things are progressing. So we look at lots of things. Of course, we look at your blood tests, and those blood tests are helpful. I hope those of you who come to the Birmingham Clinic are registered with James's brilliant My Health system, so you can actually check your own blood tests and really begin to understand those tests yourself. And those tests tell us different things. So some of those tests tell us about the PSC, so things like the alkaline phosphatase and the gamma GT come from the bile ducts, which are damaged in PSC, so that tells us directly about the damage to the bile ducts. Others of the tests we look at tell us about how the liver is actually functioning. So the liver makes proteins in particular, and when the liver is beginning to struggle, it doesn't make that protein as well as it does normally. So things like the albumin begin to drop. Some of the clotting factors which the liver make can drop, and that can lead to an increase in something called the prothrombin time, which is how quickly your blood clots. So we can look at all these factors, and of course the bilirubin is the one that gives you the jaundice, which is a factor that's cleared by the liver. So that tells us a little bit about the liver function as well. And it's really putting all these things together which tells us whether there are warning signs there that your liver might be deteriorating. And again here, it's really important to know your past results and your past history, because some people go on for years with blood tests which look pretty awful, but they feel well and they don't have problems. Other patients, blood tests aren't so bad, but suddenly they'll develop symptoms. So we need to know and understand what's gone on in your past to be able to predict what's going to happen in the future. Of course, the other things we do to assess the liver are imaging. So we do ultrasounds frequently when you come. So ultrasounds will give us some idea as what's happening in the bile ducts and if there are any strictures and any areas of dilated bile ducts within the liver. They also help us to look to see if you're developing early signs of liver cancer, which is a risk for anybody with liver disease. And that's really important to do, because if we pick that up early, we can cure it. Whereas if it is allowed to progress, it can become a very difficult thing to treat. And then, of course, the other investigations we do are MRI scans. And I was talking to William earlier. Some of you might have been involved with the trial looking at this new MRI scan that Gideon is running in collaboration with the team in Oxford. And Gideon may talk a little bit more about this later. But the MRI scans give us much more detail look at the liver and a very detailed look at the bile ducts. And we hope this new scan may give us even more information about how inflamed and how scarred the liver is. But what the MRI allows us to do is to look to see whether those narrowings and stricturing in the bile duct is changing. And if it is, and if, for instance, you've come in with fever and shakes and jaundice, and we do the MRI scan and we see that there's a new stricture appeared in the duct, a narrowing in the duct, then sometimes we can actually go in and stretch that and dilate that narrowing and allow the bowel to drain, and the symptoms will improve. So it's a very important way of monitoring the liver over time. And again, it's important that we've got all your old scans to go back and look at, because some scans can look horrendous and the patient is actually great. So if there hasn't been a change, we leave it alone. Other patients will have a sudden change, and that's when we might want to move in and do something about that. So when it comes down to transplantation, which is, some of you will know, an extremely effective treatment for the group of patients with PSC who go on to develop end-stage liver disease. Of course, not everybody will. Many patients may be stable with PSC for years and never need a transplant. But for that group of patients who do need a transplant, then it's putting all of this information together and talking to you about your symptoms and how you feel, which allows us to make that decision as to when to put you forward. And of course, it's a balance, because although nowadays we expect 95+% of patients who have a liver transplant to go on, not just to get through the operation, but to go on and get back to a really good quality of life, it is still a risk, and it's a major operation. And of course, we don't want to put anybody through a transplant if their disease is just at one of those troughs and will actually pick up and recover on its own. So it's a difficult assessment, and it's an assessment we make with you, taking into account your symptoms and how you feel as well. So I think Martine asked me to talk a little bit about some of the symptoms I know that really bother you, and these are the itching and the fatigue and some of the non-specific pain and the just feeling awful and the poor sleeping. And again, these symptoms, particularly the profound fatigue, doesn't affect everybody with PSC, but some patients really are hit hard by it. And it used to be something that we really didn't understand at all, because the fatigue in particular can occur in patients whose liver tests actually look pretty good. And there was a temptation before to sort of put it all down to the patient being a bit neurotic about their disease. But of course, over the years, we've really looked into these sort of softer symptoms, if you like, and have demonstrated now mechanisms that underlie them. And both the itching and particularly the fatigue are a consequence of the ongoing inflammation in your body, which releases factors that in the context of fatigue actually directly affect the brain and affect factors that work within the brain, and that can cause what's called sickness behavior, and fatigue is a very profound part of that. So we now know that this is a real entity. It's not just you being neurotic. Unfortunately, at the moment, we don't have very good treatments for it. And over the years, many different things have been tried, and there are new treatments coming through into clinical trials that may help. But it can just be a very disabling symptom. I think one of the things that does work, if you're well enough to do it for the fatigue, is actually, ironically, regular exercise. The more you exercise, actually, the more you can control and manage that fatigue. Another common symptom which patients complain of is pain, this sort of vague right upper quadrant pain over the liver area. Sometimes that can be associated with fevers and sweats and shakes in a subgroup of patients, and that may be associated with infection in the biliary system, and sometimes that responds very well to antibiotics, either a short course, or some of you may actually end up being put on long-term antibiotics to keep the bile clear. But other patients get pain really for again, no very obvious reason, and I know some patients get very fed up when you come to hospital complaining of pain, and we sit there and go through it all and look at your scans and say, well, actually, I'm sorry, I don't know what's causing it, and there's nothing we can do. So some of these symptoms can be very frustrating. But if there is anything that we can treat and deal with, then obviously we'll look for that and try and cope with that. So finally, I just want to talk a little bit about some of our current understanding of how PSC occurs and how it's driven, because I think the story is becoming more and more interesting, but of course the more we find out, the more there is to find out, and the more complicated it becomes. So one of the hypotheses that my lab came up with 15 or so years ago now to link the gut and the liver was that actually PSC is a disease that's driven by the gut. So it's the immune system in the gut that becomes activated, and then that immune system, which is normally confined to the gut to deal with inflammation and infection in the gut, for reasons we didn't understand, spills over and begins to attack the liver. And we showed that this is at least part of the case because we know the type of immune cells that reside in the gut, and we could show that those cells were in the liver in patients with PSC and not in the liver in other liver diseases. And we were able to show that one of the reasons that the liver gets attacked is that to the immune system it begins to look like the gut. So these cells that are supposed to be working in the gut think the liver is the gut and get, if you like, sort of diverted into the liver. And recently, in some work that Gideon and a talented young couple of young research fellows in the lab, actually, Palak Trivedi, who some of you might have met, and Nabil Qureshi had done, we found another really interesting component to this link between the gut and the liver, and that's related to the bugs that we all have within our gut. So you might have heard people talk about the microbiome or talk about the gut as this, or the bugs in the gut as another organ within the body. And if we actually, you know that we're made up of genes and of DNA. If we actually look at all the DNA that's in you or me, the vast majority of that is bacterial DNA. It's not human DNA at all. And our guts, of course, are the main site where these bugs reside. They live on the skin, they live in other surfaces, but they live particularly in the gut. And what's become really interesting, and really only over the last 10 or 15 years, is that these the bugs in the gut are not bad bugs. These are things that we've evolved with for hundreds of thousands of years, and they actually shape how our bodies work. So they shape how our immune system works in the gut. If you don't have the right bugs, your immune system doesn't work properly. They also shape how you metabolize things. So if you have the wrong bugs in the gut, you can become obese. So in the lab, we can take obese mice and non-obese mice, and mice are a bit disgusting, they eat each other's feces. And if you swap them over, so you get the thin mice in the cage where the obese mice were, they become obese by eating the feces of the obese mice and by taking on the bugs in their gut. So this is an amazing area of science at the moment, and we're really beginning, just at the beginning phase of trying to understand the complexity of this. And what Gideon's group have shown is that the bugs in the gut in PSC are slightly different from the bugs in the gut in healthy people, and interesting, they're also slightly different from the bugs in the gut of people with other liver diseases and of people who have inflammatory bowel disease on their own. So it seems that there is a distinct profile in PSC. And one of the things that we think is a consequence of that slight change in profile is that those bugs produce factors that may then actually go to the liver and slightly change the liver to make the liver look a bit more like the gut. So we're just at the beginning of trying to understand all this, but it's going to be, I think, a really important area of research in the future. And this does have direct implications for treatment, because there is a molecule which is at the center of all of this, and it's a molecule that I first published research on in 1996. It tells you how long things take to come through in science sometimes. But this molecule is called vascular adhesion protein 1, and we think this is absolutely critical to the way that PSC develops. And we've had funding recently from the National Institutes of Health Research and the Medical Research Council to carry out a trial targeting this molecule in PSC, and Gideon is leading this trial, and it's going to be in collaboration with the group in Oxford as well. And we are now at the point of recruiting patients to receive this treatment. So if we can demonstrate that by targeting this new molecule we can actually modulate the course of PSC, then that really could be the beginnings of one of the first treatments to actually change and try and switch off this whole process that drives the disease. And Gideon may well talk about some of the other really interesting trials that are coming forward in PSC. Some of them related to the hypothesis I've told you about, others related to other elements of PSC, because it's some of the other bits that drive the disease is defects within the biliary system, the bile ducts itself, that makes the bile within the liver. So I think, as I say, I've been looking after patients with PSC sort of on and off for 30 years, and for most of that time we didn't understand the disease, we had no treatments. Transplantation began to come through for that group of people who have really aggressive disease. But otherwise, we were really stuck. I think we're about to enter a very exciting phase when we are going to have new treatments. And some of those I have real hopes will begin to actually modify this terrible disease, and hopefully, at some point, come up with treatments that it'd be great if we could actually cure the disease, but certainly can really slow down the disease. And if you think of some of the advances, you might think this is all pie in the sky, but if you think of some of the advances that have happened in other related diseases over the last 10 or 15 years, inflammatory bowel disease, for instance, and particularly rheumatoid arthritis. Rheumatoid arthritis used to be a terrible, crippling disease. Now most patients, if they're caught early enough and treated with some of these new treatments, their joints can be returned to normal and the disease can be switched off. So I'm just hopeful that we're entering a phase where the same will apply to PSC.